My name is Dr. Chevalier. Appreciate everybody joining us here today. It's my honor to introduce to you Carolyn Coco-Ross, MD, MPH, CEDS, who's a physician, international speaker, and consultant on the issues of mental health, trauma, workplace productivity, and intergenerational trauma. Dr. Ross is a graduate of the University of Michigan Medical School, and she completed a residency in preventive medicine and a master's in public health at Loma Linda University and a fellowship in integrative medicine at the University of Arizona. She's board certified in preventative medicine and addiction medicine. She's presented at TEDx Pleasant Grove Talk on historical and intergenerational trauma in January 2020. She's also the co-founder of Inclusive Minds Consultants, a group that offers trainings to organizations on creating trauma-informed, inclusive, and equitable workplaces. She's a co-editor of a book soon to be published, Anti-Blackness and the Stories of Authentic Allies, Lived Experiences in the Fight Against Institutionalized Racism, which is due out next month. Dr. Ross is also, to the best of my knowledge, our only returning speaker for this series. She's back by popular demand, and so I'll leave you in her capable hands. Questions will be available at the end, so please feel free to save them for us, and I'll be happy to get to them and share those with Dr. Ross.
Okay, Dr. Chevalier, kudos. You went through that at record speed and got it all in. I'm amazed. Well, let's get started. Okay, so here's our topic. I'm just going to dive right in here. We know that the prevalence of eating disorders and addictions is really big and growing. There are around 5.5% of women in the United States, which is over 7 million women who have substance use disorders, and 15.4% of US women who report that they've used some substances in the previous year. So it's a big problem. And the rate of drug overdoses in women is increasing even faster than overdoses in men. We know that that includes the opioid use epidemic, as well as increases in the use of benzodiazepines and cocaine. So you can see the numbers here, and I think what's really important is these numbers don't really represent everybody who has these disorders. While many people with substance use disorders are being counted who are people of color, we know that there's a huge underdiagnosis of eating disorders in people of color. So that's the market share that's not really being addressed. And in the treatment world, the same goes for substance use disorders. We have a lot of people who are using substances who need treatment and are not getting it. So one of the problems with that is societal bias. There's the bias that, for example, Black women love being in curvy bodies. They don't have eating disorders. They can't get eating disorders. I've been speaking on that particular topic for probably 7, 8 years. And we now know, and the research is still lagging, but we do know that from the research we have that the prevalence of eating disorders is the same in BIPOC individuals, Black, Indigenous people of color, as it is in whites. But there's still a lot of bias about seeking treatment, and there's cultural bias as well. And I'm going to talk a little bit about that. So, for white individuals who are coming in for treatment or who are needing treatment, there's just this neutrality about it. It's not a big deal. They're not having to face a whole wall of issues aside from their medical condition in order to enter treatment. The cultural norms and medical practices really are white centered, and that can lead to a sense of comfort in some ways. If you have to get treatment, you know, you don't have that extra barrier of the cultural issues. And there's also a sense of trust and comfort. Most providers are uh, white, and therefore, they're seeing someone who looks just like them, like the doctors they have at home. Similarly with therapists, the same. And then finally, there's bias in diagnosis and treatment, as I mentioned. While white individuals can experience fewer biases in diagnosis and treatment compared to BIPOC individuals, there can still be, however, gender, socioeconomic, and other biases that can affect their health care. So we're not saying it's a walk in the park if you're white, but it's a lot easier. So part of the issue has to do with what we call privilege, which some we used to call white privilege, but there's privilege of all sorts. And this privilege that we experience, as I'll show you in the video here, really creates a bias when we approach patients of color, or patients who are in any way different from us. So let's take a look at the video, and I think that'll give you a good idea.
Some people are born into families where they have to walk miles just to get water. All I have to do is turn on a faucet. That's privilege.
If you have ever tried to change your speech, if you were embarrassed about your clothes or house, if you would never think twice about calling the police or trouble.
I think privilege is when some people have some things and other people don't have things.
I feel privilege is something that you don't even really have control over. I think it'd be silly for me to say I don't have a fair amount of privilege, considering like the country I live in and the job I get to do and the college I was allowed to go to.
I suppose being a white male will help me end up somewhere towards the front, but I'll take a few steps back from being gay.
I don't think I'll make it to the front. I think I'll maybe be in the middle. That's just the gut feeling I have.
If your parents work nights and weekends to support your family, take one step back. If you can show affection for your romantic partner in public without fear of ridicule or violence, take one step forward. If you were embarrassed about your clothes or house while growing up, take one step back. If you have ever been diagnosed as having a physical or mental illness or disability, take one step back. If you have ever been bullied or made fun of based on something you can't change, take one step back. If you get time off for your religious holidays, take one step forward. If you came from a supportive family environment, if you can see a doctor whenever you feel the need, if you are able to move through the world without fear of you took out loans for your education, if there were more than 50 books in your house for you. So these are your final positions.
I think it felt kind of strange for everyone.
It's a hard thing to discuss or even reflect on. It was very awkward. I think when you can represent it so visually like this and so immediately, it definitely takes on a new form.
I think we were like all joking around in the beginning. It was pretty lighthearted. And as soon as the questions started coming in, the mood shifted immediately. And we all it was just silent.
Just looking back and seeing like a bunch of people behind you is not a good feeling.
It's like weird how you want to like hold on to explaining a certain privilege. Like, oh, but that's not actually me because like I had to work really hard for that. So it's weird to like take a step forward when you feel like you're taking a step forward with someone else, but you wear a lot of the baggage of like how those things were hard.
It was like more emotional than I thought it would be.
It reminded me of when they talk about slavery in high school and you feel like angry for a few days, but then you just realize like, this is how it is.
For me, it was kind of frustrating almost to look back and see how much further some people were behind me and realizing that, you know, a lot of that stuff, no amount of hard work or even legislation can make up that gap.
It's interesting being an Asian American because you're not really sure where you fall on the spectrum of privilege.
I know that for me, one of the reasons I ended up so far back was that there are questions around safety as an African American, as a woman, as a gay woman. There are just so many different ways that I don't feel safe.
I feel like I just learned to be grateful for what you have. You know, we're in such a huge society where it's always complaining about what you don't have.
It just shows you that for some families, like each family, you're meant to do better. My grandparents did good. My parents did good, and I'll do even better.
I do think if you're not like aware of privilege, you should do this exercise, but it's more complicated.
Some people are.
Yeah, so I just want you to reflect on if you're one of the people in the front of that room, for example, and then you have patients coming in to see you, and they're from the back of the room, then how are you going to bridge that gap? How are you going to understand, for example, where they don't feel safe or what doesn't what makes them not feel safe? What are the things that you can say that might be misinterpreted because of your privilege? So that's why I want to show that video, and I hope you'll take time to reflect on that a little bit. So let's now look at the experience of a BIPOC individual coming in for treatment. There may be a long history of unethical studies, not maybe, there have been long history of unethical studies, such as the Tuskegee syphilis study among African Americans, forced sterilization among Native American women, and that all contributes to this feeling of deep mistrust in the healthcare system in general. And if you think that's all just historical, think again. During the problems that the immigrants experienced at the border under the Trump administration, there was an expose that came out that showed that Latinx women were being sterilized without their permission on a pretty large scale. You know, they were taken to see a doctor, and the next thing they knew, they were sterilized. And so this kind of mentality continues, and these behaviors also continue. So this video I want to show you now is about that history of unethical practices. I won't be able to show you the entire video, but if you want, I can put the link in the chat later. So let's look at what we can see.
At the edge of Central Park in Manhattan, there's a bronze statue of a doctor named James Marion Sims, whose brilliant achievement carried the fame of American surgery throughout the entire world. He's the guy who created the vaginal speculum, an instrument gynecologists use for examination. He pioneered the surgical repair for fistula, a complication from childbirth, and became known as the father of modern gynecology. But that brilliant achievement was the result of a series of excruciating experimental surgeries that he conducted on enslaved women. In a lot of ways, Sims epitomizes the story of American medicine for Black women. It's a system that's failing them to this day. From infant mortality to life expectancy, the racial disparities in healthcare are staggering. The gulf between Black and white might be widest when we look at maternal mortality, with Black women 3 to 4 times more likely to die in connection with pregnancy or birth than white women. And that divide can be traced back to doctors like Sims, who contributed to a long, largely overlooked history of institutional racism in medicine.
Trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting a thorough medical history. You're doomed to failure.
That's Harriet Washington, a medical ethicist and author who chronicled the intersection of race and medicine in her book, Medical Apartheid. While many of the stark racial disparities in healthcare can be attributed to environmental and economic factors like access to good healthcare, studies show that minority patients tend to receive a lower quality of care than non-minorities, even when they have the same types of health insurance or the same ability to pay for care.
As African Americans, we've been abused for so long, consistently by the system. Why should we trust it? Why should we go to it when ill? And that's iatrophobia. That's a fear of the healer, inculcated by the behavior of those healers, unfortunately.
It starts with slavery. Doctors relied on slave owners for financial stability. They accompanied plantation masters to auctions to verify the fitness of slaves and were called in to treat sick slaves to protect their owners' investments. In 1807, Congress abolished the importation of slaves and in turn pushed Black women to have more children, to essentially breed slaves. Founding Father Thomas Jefferson later wrote, "I consider a woman who brings a child every 2 years as more profitable than the best man on the farm." Around the 1830s, the abolitionist movement led to the rise of what was called Negro medicine, or efforts to identify Black inferiority to justify slavery. And there were polygenists who tried to use both science and the Bible to find proof that races evolved from different origins. The 1830s also marked the beginning of recorded experimentation on Black women's bodies. One doctor performed experimental C-sections on slaves. Another one perfected the dangerous ovariotomy, or removal of an ovary by testing the procedure on slave women. In fact, half the original articles in the 1836 Southern Medical and Surgical Journal dealt with experiments on Black people. And then, of course, there was James Marion Sims, whose reputation is etched in history and on that statue in Central Park. Between 1845 and 1849, Sims began performing experimental surgeries on a 17-year-old slave named Anarcha. He eventually performed 30 operations on Anarcha and more surgeries on about 11 other female slaves. When his male colleagues could no longer bear to assist him in inflicting pain on the women, the slaves took turns restraining one another. Yet paintings depicting Sims, Anarcha, and other slave women presented a subdued version of his experiments. Even though anesthesia was introduced in 1846, Sims chose not to use it for his experimentation with slaves. His practices echoed one of the most prevalent and dangerous beliefs in medicine at the time, that Black people did not feel pain or anxiety. This book from 1851, titled The Natural History of Human Species, claimed the American dark races bear with indifference tortures insupportable to a white man. Studies released as recently as last year demonstrate that Black people are less likely to be treated for pain, particularly in the ER. There's even one from a children's hospital that found the same to be true for kids. And just this year, Pearson Education, a leading educational publisher, issued an apology and recalled nursing textbooks that included racist stereotypes, like this section that said Black people often report higher pain intensity than other cultures.
Well, what does it mean when you say that someone doesn't feel pain? Among other things, you're speaking about their humanity. These are all part of that suite of beliefs emanating from the 19th century that we still have not shaken off, despite all our knowledge and sophistication. They're deeply ingrained.
Doctors like Sims might fit the Dr. Frankenstein stereotype.
Okay, I think that should give you a bit of an understanding. And when you speak with African Americans, this kind of knowledge is passed through the generations. So it's talked about in families, the Tuskegee experiment, where people were were not treated who had syphilis, and they were just observed for symptoms. That came up during the pandemic, where a lot of young Black people decided not to take the vaccine, for example, because of that fear that dating back to those historical traumas. So another issue that BIPOC individuals face when seeking treatment is the lack of really cultural competence and representation. So we know that Black and Indigenous people of color healthcare providers are underrepresented in these professions, and there's a sense that there's less cultural competency, which can lead to misunderstandings, miscommunication, and less culturally sensitive care. We mentioned the stigma, but stigma in some BIPOC communities around mental and behavioral health issues is pretty high. I think that's starting to go down a bit, but cultural beliefs about you need to take care of this yourself, you shouldn't need help, or you need to take it to God. That's a big one because of the prominence, particularly in the Black community, of the church. So that can help people keep people from seeking treatment when they need it. There's also the issue of racial bias and discrimination. We've talked a little bit about bias and its relationship to stereotyping and privilege. But these biases can lead to disparities in diagnosis, in treatment options, and in the quality of care that's received. In terms of mental health care, we know from research that Black patients are more likely to be diagnosed as schizophrenic, than to be given a more accurate diagnosis. They're more likely to be incarcerated rather than to be put into treatment, and so on. And then finally, there's so many barriers to access, and some of these have to do with socioeconomic barriers, such as there being more people who are uninsured or underinsured, even in BIPOC communities. And this leads to, inability to actually access treatment because of cost in many cases. There can be fewer healthcare resources, obvious systemic inequities, and so on. So what that means is, if you're a white individual, you're more likely to seek treatment. Now, we know that for people with eating disorders and substance use disorders, it's very difficult to get them into treatment. But I'm saying if you have a playing field where some people don't have to overcome racial or discrimination barriers, it's easier to get into treatment. And then for BIPOC individuals, they may delay or avoid treatment due to these issues that we just discussed. Obviously, there's a lot of work that needs to be done systemically that doesn't necessarily have to do with the work we do with patients, but we need to be aware of those issues. So here's some of the demographic disparities in eating disorder and substance use disorders. You can see here in the dark blue, in the dark blue are white patients who have been able to go into treatment. So this pie chart is all about the disparities in eating disorder diagnoses, with white individuals making up the majority of those diagnosed. And then next is Hispanic or Latinx, and then Black, Asian, and LGBTQ+. So for all of those, people in the lighter blue colors, you can see that while they may have the same prevalence of eating disorders and substance use disorders, they aren't getting diagnosed at the same basis, at the same level. And then, of course, the issue of representation comes up. I think, when you think about that, I think only 30% of providers have come from BIPOC communities. That represents a huge problem. Mental health and other health issues are, as I said, are stigmatized. And we know that for people who even have a doctor in their neighborhood, they tend to have much better outcomes than someone who does not have access to care from someone who looks like them. Research shows that there's better adherence to medication. There's better satisfaction when a patient can connect with providers who are from the same racial, ethnic, or cultural identity. And then representation of LGBTQ+ individuals in the mental health environments is also a problem. So, as I said, less than 30% of licensed professional counselors in the United States are part of the BIPOC community. And the lack of providers presents another barrier. This study that was done in 2023 found that for every 10% increase in Black primary care physicians, life expectancy increased by about 1 month. The study also found that Black people live longer in areas with more Black doctors. Now, some say that increasing the representation of Black physicians is important for improving public health. That's also been shown in one study that found that Black men who were assigned to a Black doctor were more likely to bring up other health problems, and Black doctors were more likely to write notes about their patients and to pay attention to their complaints. So this just points to better communication between Black patients and Black doctors. And even people who are not directly treated by Black physicians can benefit from their presence. For example, patients may fare better simply by living in counties that have Black doctors. So a 2019 study in Oakland, California found that heart disease could be reduced more in Black patients who are seen by Black doctors because they are more likely to engage in preventive health care. So this is the number of providers by race. Today, all healthcare providers really should be trained in cultural competence, but As we know, it takes a long time to change things in medicine, so that's not happening. But according to counseling.org, it is vital to have culturally competent professional counselors provide a safe and trusting environment and assist in eradicating minority stigma, bias, and mental health misdiagnoses. If we are able to increase cultural diversity, then BIPOC individuals will have more ability to establish strong, trusting relationships and break through those barriers that keep them from accessing care. So, here are some of the things that impact the client's engagement. First of all, is language. So, we know that that inclusive language respects diverse gender identities, sexual orientation, race, ethnicity, and cultural backgrounds. And that's crucial so that people feel seen and valued and empowered to engage openly in the treatment process. So, this sense of validation and belonging creates that bond, that therapeutic bond that helps patients trust us. So, research shows that clients who feel their identities and lived experiences are validated through the use of inclusive language are more likely to actively participate in their care, adhere to treatment recommendations, and have better long term outcomes. So, it's really as part of creating an equitable, person centered treatment, it's important to focus on language. The other part is intersectionality and how that can affect treatment outcomes. So, intersectionality, we all know what it means, but it really just is about recognizing that there are different aspects of our identities, such as gender, race, ethnicity, socioeconomic status, sexual orientation, disability status. When you look at the Adverse Childhood Experiences Study, which I spoke more about in the last uh, presentation I did, the Centers for Disease Control has added a level to the pyramid that they first created, which is first they've added historical and intergenerational trauma, but they've also added this concept in the ACE study of adverse community environments. So that's focusing on socioeconomic status, safety, poverty, and so on. So those are all aspects that have a tremendous impact on our health and well-being. So I want to just talk about a few key phrases about racism. So individual racism refers to the beliefs, attitudes, and actions of individuals that support or perpetuate racism in either conscious or unconscious ways. So we know that in the United States, being raised in the United States is like, being surrounded by a mist of racism that we're breathing in all the time, that our children breathe in. And that really becomes part of our, I could say, quote unquote, DNA. It's not part of the DNA, but it's certainly part of our day to day understanding of who we are and who other people are, and so on. So, an example of this is believing in the superiority of white people, not hiring a person of color because, quote unquote, something doesn't feel right, or telling a racist joke, or on the reverse, hiring a white person because they remind you of your daughter, or they remind you of yourself, or you had a shared experience with them. For example, you were in treatment yourself with them, and so that feels safe to you. Those are all examples of either implicit or explicit bias and racism. Now, the second type is interpersonal racism, which occurs between individuals and includes public expressions of racism, like racial slurs, using the N word, or different actions excluding people from social groups or activities, or microaggressions, which are those subtle, often unintentional comments or actions that devalue another person. So that's like, where are you really from? oh, you speak such good English, or, things of that nature. I'm sure most of you have heard about that. And then there's institutional racism, which occurs also in organizations. And these are race based policies and practices that give unfair advantage to whites over people of color. These institutional policies often never mention a specific racial group, but the intent is very clear that it keeps white people having the advantage over BIPOC individuals. So, for example, a school system where students of color are more frequently distributed into the most crowded classrooms and underfunded schools and out of the highest resource schools. So, the whole charter school movement is a perfect example of that. We have charter schools because people want to emphasize, for example, religion, but the underlying aspect of that is that it can also emphasize white supremacy and perpetuate white supremacy. And then finally, structural racism is the overarching system of racial bias. So that's that mist that we all have been breathing since the day we were born. It goes across institutions and society. These systems give privilege to white people, resulting in disadvantages to people of color. So, one example of that is stereotypes of people of color as criminals in mainstream movies and media. So, for example, another example in my work, I had an assistant who I asked to put together a graphic for a social media post, and the social media post was about how trauma can be triggered in the workplace. So, one example of that are people who are rageaholics in the workplace. We see that in medicine all the time, and maybe some of you have seen that in your training. I interned with a doctor who used to throw charts at his nurse. And so I asked her to do a graphic for that, but the graphic she turned in showed a Black man being very angry in a work meeting. And that really, while that certainly happens, I'm sure, that plays into that stereotype of the angry Black man, or it could have been a woman, the angry Black woman. So that's a stereotype that continues to support these, the structural racism. So, how do we address these unconscious biases when we're doing clinical assessments and when we're trying to admit patients with either eating disorders or substance use disorders? Well, the first thing is to be more aware of your own biases. And I really encourage all of you to take the Harvard's implicit bias test. It's called the IAT, implicit assessment test, I believe. But anyway, you can just Google Harvard, implicit bias test, and you'll get it. When you do that test, it shows you pretty dramatically whether you're biased towards white individuals or towards BIPOC individuals. And the bias, they have about, I think, 10 or 15 areas where you can check your bias. And one of them is weight bias. So that would be good for anyone who's working with uh, eating disorders to check whether they have bias against people of size. And then they have racial bias. They have colorism bias. So if you may say you may be African American, but you have a preference for, or you're biased towards people who are lighter skinned. So I would encourage each and every one of you to take at least one of those tests and identify your biases, and then start looking in your day-to-day life as to where these biases show up. For example, if you're in power and you're interviewing people, I spoke with a friend of mine who was the executive director of a treatment facility, and she was in an interview with her colleagues. And at the end of the interview, she asked, "Well, who do you think we should take?" And her colleague said, "Oh," he pointed to the young white woman. And she said, "Well, why do you want to choose her?" And he said, "Well, she just reminds me so much of my daughter." But when you looked at the statistics, when you looked at the facts, the young Black woman had extensive experience in working in a treatment center, very well educated, great recommendations, and so on, whereas the young white woman had no experience, and on down the line. So these things we do unconsciously, we have to bring to conscious awareness. And then after you do that, it's important to do some training, whether it be on your own or in groups like this, where you can develop cultural competence. That's critical. And then change your paperwork so that you can reduce the risk that you will act from biases. So adapt your assessment tools and your processes to be more sensitive to diverse cultural norms, languages, and perspectives. So I'm just going to ask you to do a little exercise now. And if you would like, you can put your responses in the chat box, or you can put your experience in the chat box. And then we can talk a little bit about that. So this is called the first racialized memory experience. And this is from Beverly Daniels Tatum, who is a well-known activist in this area. So just think for a moment about what is your earliest memory of learning about race or becoming aware of race? Think for a moment, the earliest memory you have that concerned becoming aware of race. Now get in touch with what that felt like. Did it feel confusing, fearful, shameful? What did it feel like? At the time that you had that experience, did you talk with anyone about it? And if so, how did they respond? Okay, so one person said they were 5 years old and it was embarrassing and she kept it to herself. See if there are any others. Anybody else want to add to that? Okay, well, usually people are between the ages of 4 and 5. Let's see, I have another one here. Yeah, I was in 4th grade and I was confused and scared. Great, yeah. Anybody else want to add? Well, like I said, usually people are between 4 and 5, and usually the children don't go and tell anybody about it. They internalize it, and this is an internalization so early that you're given that message of not to talk about race or not to ask about race. So another person said, I was very young and I was afraid. When I was very young, my grandparents had quote unquote staff that they were not very nice to, and I was very uncomfortable about that. My mom explained and said it was not okay that my grandparents behaved that way. Another person, I was quite young and my family made racial comments about a food item. I questioned them and they told me it didn't matter because we don't have people of color in our family. Wow, these are some great memories. Another person says, I remember being in kindergarten and a boy said, who wants to come to his Christmas party? Then looked at me and said, no blacks. And I put my hand down. Oof. Another person said they were 4 to 5 years old. I remember the boys down the street were Latin, and my dad always talked how good they made salsa. I don't remember feeling much around it. Okay, so from all of these, you can see what we're saying, which is that people are very young when they have their first awareness of race. And we get a lot of practice at not talking about race, and that makes it difficult to get conversations going. And even as adults, that childhood memory may influence your comfort level with, starting or having conversations around race. But we can't really solve problems that we don't talk about. And I think that's what we're seeing in our country as a whole, that people don't want to talk about problems. They just get mad. But this causes anxiety, and we get nervous when we start talking about race, which makes everything harder. So we need to really work on pushing past our anxiety. I had a couple more shares here. I guess I should add, my mom did not have much positive things to say about Arab folks at that point. People would try to identify me as white. I am Greek. When I went to preschool age 3, I only spoke Greek. No one thought I was white back then and just looked at me like I was an alien because I didn't speak English. I felt very lonely. Okay. Thanks, everybody, for sharing. That's really helpful. Okay, so what do we need to do? How do we need to go about developing culturally responsive treatment? Well, I think it's really important to recognize that, you actually have to change something. You can't just have seminars and expect the systems within your treatment center or your office to change. So you have to really sit down and either get coaching from someone or work on this yourself through reading and researching, but adapt evidence-based practices to be culturally relevant, do collaborative care, and work on inclusive language. So one of the things that I talk a lot about is trauma-informed care, because trauma-informed care really recognizes that harmful behaviors like, disordered eating and substance use can and are related to past traumas. And by acknowledging the underlying trauma and recognizing that BIPOC individuals have much higher rates of trauma than do white individuals. So, for example, 60% of Black children have at least one adverse childhood experience. And I think it's 45% of Latin children do, whereas only 23% of Asians, and I can't remember the number for whites, but it was much lower. So again, if you're not treating trauma, then you're not being culturally responsive, because that's going to come up. Obviously, it comes up in white patients too, because substance use disorders have their roots in trauma, as do eating disorders. So that's one way in which trauma-informed care can color your understanding of cultural, historical, and gender issues, and that can help you to become more culturally responsive. The other thing that I think a lot of people don't do, and I remember when I was a young doctor working in a small town in Texas, I did this all the time, but engage local organizations. I used to go and do blood pressure screenings when I was in primary care back then, do blood pressure screenings in Black churches. I would, attend community events. I would speak on certain topics in various community organizations, uh, nonprofits, and so on. When you do that, when you get out into these local organizations, first of all, you're going to learn a lot about BIPOC communities. And second of all, you may um, be able to attract clients who see you at least trying to get out there and partner with them. You can host informative events and just use a lot of variety in what you talk about and what your message is. Um, you collaborate with community leaders and others who may have more experience in culturally competent care. So here are some strategies that can be used for recruiting and retaining clinicians, because I know this is a problem. Recruiting and retaining BIPOC clinicians is a big problem. So, I think the main thing is creating a workplace culture that is psychologically safe and culturally sensitive is the most important thing you can do. But providing mentorship really helps both. It's a two-way street. It helps the employee that you attract, and it also helps the person who's mentoring, if they are maybe not a BIPOC person, to learn more about the challenges that these clinicians may experience. Obviously, outreach is important. Again, partnering with, if you have local universities that are doing trainings, do internships, or other ways that you can start to integrate BIPOC clinicians, techs, et cetera, into your workplace. Offer competitive benefits. And the most important thing I cannot emphasize enough is that inclusive culture. So intake processes and their benefits, look at this client-centered approach, thinking about, what kind of questions you should be asking your BIPOC potential clients. What kind of information do you need to get from their history? How can you understand the challenges that they're experiencing in their lives? They may not tell you they don't have a car, and therefore it's going to be hard for them to get to an IOP, for example, because they live across town, or their insurance may not cover them. Do you have any availability of scholarshiping them? Even in my private practice, I continue to have patients that I see at reduced cost um, or free, because they just can't afford it, but they need the help. And so we can't do that for everybody, but whatever little you can do is useful. Also, don't assume that people will need financial help, because there's the wealth of BIPOC communities is growing rapidly. I think they're estimating in 2030 it'll be at $3 trillion. So there are a lot of people who can afford to pay out of pocket for care. But the most important thing, as it is for the employee, is that welcoming environment. So if someone walks into your treatment center, as I did recently to a treatment center that I visited in the South, and you see pictures of plantations, or your facility looks like a plantation, or you see pictures of only old white guys on your wall, that's a problem for most BIPOC individuals. You don't have to be flying the Mexican flag or, anything like that to attract people of color, but you do need to provide a welcoming, safe environment that acknowledges that some of the things that white people are comfortable with will not be the same things that BIPOC individuals are comfortable with. Then how do you work on addressing barriers? Can you make single case agreements with certain insurances? Can you take a certain number of Medi-Cal patients? You don't have to take 100%, but taking 10% will help a vast array of people who are needing help. Look at your language on your brochures, on your website. Don't just put up pictures of a few Black and Latin people. That's what we call ticking the box. You can tick the box by having one webinar, and you can tick the box by putting up a few brown and Black people on your website, but that's not really going to create a workplace culture that's client-centered and culturally responsive. And then how do you build rapport with someone who's so different, maybe from you, whose background is so different? There's so many things that you can do, even acknowledging, hey, I don't have experience in this area or that area, but I would love to hear more about your experience. I'm sure most of you have heard it's not good to make the mistake of expecting your BIPOC friends or colleagues to teach you everything you need to know. Pick up some books. There's literally hundreds of books since 2020 on these issues. And so, start a book club where you read something on anti-racism once a month or once a quarter and discuss it, et cetera, et cetera. So those are some of the things that you can start working on. You can also obviously hire a consultant such as myself to work with you on this this type of care. So I talked a little bit about trauma-informed care, so I'm going to pass over that one. And I just wanted to mention a couple of examples within the eating disorder world that I've heard so many times. So first of all, culturally sensitive meal planning. So an example would be in a residential treatment center, a patient of South Asian descent struggles with the provided meal plans that do not accommodate her cultural dietary preferences, and instead is told you have to eat this food, this is, what's healthy for you, and so on. So if you want to help with that, what you can do is have your team work to include culturally appropriate foods in her meal plan. Support for LGBTQ plus patients. For example, a transgender patient in an eating disorder clinic feels isolated and misunderstood by staff and other patients, complicating their treatment. So what can you do? You can facilitate training for staff on gender identity and expression, ensure that the patient's preferred pronouns are respected, and create peer support groups that address the specific need of LGBTQ plus individuals. So we've seen problems with this all along, and one of the major ones I saw at the eating disorder conference is one of the speakers saying in a frustrated way, "I'm so tired of all these pronoun changes. I just can't," you know. And that's, obviously that's a very biased statement. Bias in treatment on accessibility. For example, a Black patient in an outpatient treatment program experiences subtle racial biases from staff, which affects their treatment. What can you do? Well, you can recognize and address these biases and give cultural competence training to staff and ensure that the patient's concerns are heard, but not only just heard, but acted upon, so that some action is taken so they do feel like they are not just being pulled along, but they actually were heard. Okay, so challenging stereotypes. I think we've talked quite a bit about that. And adapting evidence-based practices. So I think it important to assess cultural relevancy, um, incorporate different perspectives. We've talked about language, and then try things out and then refine them. Don't just sit on the sidelines because you don't want to do anything or you don't know what to do, which I think is the most common. When you don't know what to do a pilot project or try something out, get feedback, and then fix it if it's broken. So this is really important, which is the impact of social determinants of health. And I think these are things that we don't assess when we admit patients for treatment. So there should be questions about what your resources are. What are your fears in coming into treatment in terms of financial or insurance coverage? What is your highest level of education? How can that affect your treatment? What kind of neighborhood do you come from? Where did you grow up? That's one of the questions on my history. Where did you grow up? What was your growing up life like? What was happening in your family? All of that. And then, did you have access to healthcare growing up? And then now, do you have transportation? Do you have childcare? Can you take off work to come to treatment? And so on. We don't usually ask those questions, but that causes a lot of misunderstanding. Just imagine a patient not showing up for treatment, and then you assume that they just aren't committed to treatment, which I've seen happen over and over, when in point of fact, they just may have had a access problem. So if you can, instead of having that biased opinion, sit them down and non-judgmentally ask, can you tell me what kind of struggles you're having getting to treatment? It makes a huge difference. Same thing with relapses with substance use disorders. So many clinicians get angry at a patient when they relapse or terminate their treatment, when in point of fact, we know relapse is part of recovery. And the more you can address the relapse non-judgmentally, the more trust you'll build with the patient. The more trust you have, the better your relationship. That therapeutic bond is what's gonna help patients get through these relapse periods, not you yelling at them or making them feel ashamed of themselves. Gonna pass this. Yeah. I think we've covered most of this. This is just a slide on peer support, and I think I'll skip that too. So let's go on to advocacy and allyship, which I think is really, really important, especially nowadays where there's so much backlash against diversity, equity, inclusion approaches. So let's talk a little bit about what it means to be an ally and what it means to be an advocate. So, advocacy really is the act of supporting, defending, or arguing for a cause, a policy, or a group of people, often aimed at influencing public policy and resource allocation decisions. And that could be in the politics and economics and in social institutions or social systems. And it can involve a wide range of activities. Allyship is a little different from that. And an authentic ally is someone who supports, empowers, and stands up for a person or a group, particularly those from marginalized or underrepresented communities. Authentic allyship involves more than just saying, "Hey, I support you." It requires active engagement, and that's really key, a willingness to listen and to learn. So there's so many ways in which allyship can show up and advocacy can show up, one-on-one, or you can advocate to your facility. You can be an ally to patients. You can be an ally to staff, and so on. Okay, so I'm going to leave with this at the end. This is an exercise about using points to advance equity. So I think of this as a time when you can take a breath and recognize, hey, this is something that I can do personally. So identify a choice point. What is one of your points of opportunity to make or influence a decision that can affect racial equity outcomes? So imagine yourself, you're in a boardroom. Imagine yourself, you're in a staff meeting. Imagine yourself, you're in a supervision group with your colleagues. At any of those places, there will come a time when you'll have a choice point. And what do you do with that? Well, what are the impacts of your current decision and actions that could be intentionally or unintentionally reinforcing biases or inequities? And then generate options. What are some alternate options and decide an action? So, for example, in the example I gave you of my patient who was or my friend who was the executive director of a treatment center, and they were interviewing candidates, rather than calling out her colleague by saying, "Oh, that's dumb, your candidate has no experience, blah, blah." She just did a very factual comparison of the two candidates and compared that to the listing that they had for the job description. So in the job description, we said we wanted this, 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 and this. Candidate A, the BIPOC candidate has this, 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 and this. Candidate B, the white candidate has this and this, but she doesn't have this, this, this. So can we make a decision based on that? So look for those opportunities. I think that would be useful for you. All right, I'll turn it back over to Tammy. And do you want to take questions at this time, Tammy?
Yeah, that's exactly what we'll be doing. So anybody has any questions, feel free to enter them into the chat. We had one accidental Q&A go in there during our earlier exercise, but that will give you an idea of where you'll want to be entering it. And then I will pose those to Dr. Corker-Ross for us.
We did have one about the slides, and I'm just letting everybody know that the slides will be available in the taped version of this presentation, but the slides themselves will not be available. I do have a question. When you're working with clients who are in like a rural area and they don't have the option of seeing somebody potentially who's more aligned with the clinician that they want, How do you manage that in the best way when there's just not an option out there?
And you're saying because the rural person is not culturally competent, or
Correct.
or they're not competent in eating disorder treatment, for example?
Well, no, just culturally competent. So I think it's
Yeah,
more.
well, I mean, I think I've in the past, when I've worked in treatment centers, I've gotten calls from people like that a lot, and have worked because I think awareness has been raised that you need to be culturally competent. So I think clinicians are now aware, maybe they don't have experience or whatever. So sometimes reaching out to rural centers can create a partnership where you can help them, and making these kinds of webinars available to, as you are doing, can also be helpful. But in the past, I would actually have phone consults with doctors from all over the country, really, about, cultural competence, eating disorder treatment, substance use disorder treatment, and so on. I think we're so insular now, is my point. Everybody's in their little office or in their little treatment center, and we never the twain shall meet. But I speak all over the country. I speak at ASAM, I speak at IDEP, and so on. So I think there's plenty of opportunities to become culturally competent.
Yeah, I agree.
Yeah.
I think it's really helpful too, when we have somebody who's as educated as you are in the topic, to pass it along to our friends. When you get my email, you guys will get an enduring learner notifications. Forward that along to your colleagues, because they're looking for topics, right? They're looking for trainings that are really, really good, that educate us. But it's hard in the world of the web to go out. You could get 100 different things, and what's really good. So if you forward it, it's always better. Oh, I have run into providers being averse to crossing state boundaries and working with a client when I tried to find a good cultural match.
You can coach a provider even if you're not licensed. You just can't take over care of their patient. So what I'm talking about is coaching. So if somebody approaches you and they want that, you can say, hey, here's a great webinar that might help you, or call me if you have questions, or what are specific issues that you're running into, and you can coach them.
I was just wondering if you could tell me a little bit about your experience with the IAT. I included the Harvard's link, anybody else?
Yeah, I can tell you about my experience. They've had millions of people take this test, which I found interesting. Honestly, the first time I tried to take it, I didn't get very far. You have to like clear your desk and have 10 to 15 minutes of devoted time, because first of all, it's something different than what we usually call a test. But once you start doing it, it becomes easier. And I did this for a group of physicians down at Duke. And it was very interesting that many of them were surprised at how biased they were towards, white versus Black, or white versus BIPOC. And I think it can be a wake-up call for anyone. And even if you're Black or you're Latin, take the test, you may show some bias too. Because like I said, it's in the fog that we all breathe. And then the weight bias test, a lot of the physicians these were surgeons, and they were highly biased against people of size. And I think it was, more to do with, it makes their lives a little more complicated, but they were pretty verbal about their weight biases. So and I know I've had so many patients tell me the same, but I think it's important just to know where you're coming from. It's not to shame you or say you're a bad person or you're a racist. It's just to recognize this is the air we breathe in America. And it's very biased air. So we can blame the air we breathe. Does that answer your question, Dr. Chevalier?
Yeah, I appreciate that. And actually, in that time, we got our first question here. So let me provide that to you now. Anonymous wrote in, sometimes as an Asian American provider, I feel that most BIPOC efforts are directed at African American, Latinx, and other groups. Asian Americans are disproportionately represented in healthcare, but seem to be marginal in representation in DEI issues. Any thoughts?
I'm not sure that I would agree with that. Like, my partner in the work that we do in consulting is Korean American. And, you know, we talk about these issues all the time, but let's be honest that the biggest issue in America really hits Black Americans because of the long history and the type of slavery that we had in America. We had something called chattel slavery. And as you saw, which means people think they can own another person because they aren't real people. So that mindset has affected Black Americans for over 400 years. Now, obviously there's discrimination against Asians. I don't speak a lot about Asians because that's not my lived experience. And the statistics really show that the biggest problems, though, are with Black Americans. So in our group, we have always centered the Black lived experience because the studies show that if Black Americans move ahead, every other racial group will move with them. So if you see movement in this most entrenched area of racism, then the other groups will follow along. So I think that's probably why Black voices are centered in this arena, as it has to do with historical trauma of Black Americans. I hope I answered that question for the person who asked. It's a pleasure to be with you guys, as always. So thank you so much for having me back. I hope this was helpful for everyone.
Thanks so much for joining us again. We really appreciate it.
You're welcome. All right. Bye-bye.
All right, thanks, everybody. Have a great day.